Yes. Good morning. Hope all of you are fine, well rested in the night, and just getting up fresh in the morning. Today we will discuss something about peripheral nerve injuries. Sorry for the delay in starting the class. Delay is not because of the man, it's because of the machine. The connections were a bit disarray, and because of the problem in the connectivity, the class was delayed. So to have a good connection, either in the body or for the class, you need to have an intact nervous system. At the same time, even for the machine to work, it has to have intact connections. With that, let's go to our class. In this, we will see anatomy of the peripheral nerve, causes of nerve injuries, the pathology behind that, how do you classify nerve injuries, how do you diagnose it, how do you manage. After that, maybe in the next class, we will go for individual nerve injuries. Coming to the anatomy, most of you know anatomy of the nerve cell, neurons, axons. All these terms are very familiar to you all. But here we will touch upon a few terms and we should know what they mean. These peripheral nerves, they are a bundle of axons. It's a sheet containing so many axons as fibers. So it's akin to an electrical wire which conducts electricity. Whenever you cut a wire, as and when you find time, there are so many cables lying around in your house, and if you cut them, then if you cut the outer sheet, you will find so many copper wires bunched together. Our nerves are similar in structure, and each axon is an elongated process of a nerve cell. So this is a nerve cell, it's called neuron, and it has an elongation, it has a tail which is called a axon. And cell bodies are of two types, all of you know, motor neuron and sensory neuron. Motor neuron is the one which gets orders from the center, that is the brain. From there it gets the orders down, and the muscles or the organs, they obey the order. And sensory neurons are the neurons which transmit from the periphery to the center. Okay, so motor and sensory. And a single neuron may supply around 10 to 1000 fibers. So this nerve function is very, very important in the body. Coming to the coverings of individual nerve fibers. See here, epineurium is the outermost one. Epineurium covers the whole nerve trunk. This nerve trunk contains lot of fascicles. See, this is a bunch here, this is a bunch, and each fascicle contains lot of axons. Okay, so the whole thing is covered outside by the epineurium. Yeah, once you go inside, each fascicular bundle is covered by a perineurium, and inside perineurium, each axon is covered by endoneurium. This is like endothelium, like in blood vessels, it is endothelium. So similarly here, endoneurium inside out, endoneurium, perineurium and epineurium. So you should be familiar with these terms, because management most often depends on this. And once somebody says they have done NEURORRAPHY, you should be able to understand what they have done. So same thing, a pictorial depiction here. See, this yellow one is epineural sheet, covers the whole thing. This is the epineurium, the epineurial sheet. And this one is the perineurium. Each fascicle is bounded by a perineurium and endoneurium. Each axon has a covering of endoneurium, and these are called myelin sheaths. This myelin sheath is provided to hasten up the pace with which this is transmitted. A signal is transmitted in the nerve is enhanced by the presence of these myelin sheaths, and in between you will find this road of Nanvia. This is a unmyelinated axon. Here there is no myelin sheath, myelin covering, but here you find these myelin sheaths. So here the signal travels at a much faster rate when in a myelinated sheath than in a unmyelinated axon. Coming to the peripheral nerves, they consist of 12 cranial nerves and 31 pairs of spinal nerves. All of you know these 12 cranial nerves. I need not tell you about those things now. And these spinal nerves are 31 pairs, one on each side, right and left. And they are divided into cervical, thoracic, lumbar, sacral and coccygeal, depending upon the place at which they are emerging. Cervical indicates they are coming out from the cervical spine. Thoracic in the dorsal spine, likewise. And how do you name them? You say C8, C7, C6. How do you know that? Once you say C2, then the C2 nerve root exists between C1 and C2. So C1 and C2 place is the where you get this C2 nerve root. This emerges in between C1 and C2 vertebrae. Similarly, L4 nerve root emerges between L4 and 5 vertebrae. So if there is a disc problem, L4, 5 disc is prolapsed and it comes out and presses over L4 nerve root. So in this way you can have an idea even before you examine the patient. If you see an MRI where it shows that there is a bulge at C1, C2, the disc is out and there is a pressure on the card, then you can think that maybe C2 nerve is compromised. So if you examine the patient clinically, you should search for C2 nerve involvement. And similarly, you should search for L4 nerve root involvement when the bulge is at L4, L5. So these are the spinal nerves which are named according to the region in which they emerge. Coming to the nerve injuries per se, how do you see them happening in the clinical field? Usually they are associated with fractures and dislocations. All of you know that these nerves run very close to the bones and the joints. So whenever there is a fracture, then there is a possibility that the similar force may lead to injury of the closely lying nerve. So in supracondylar fracture, you can have injury to the median nerve, radial nerve. Like that, in a fracture of the fibula here, fracture of the fibula upper third, especially the head and neck, if there is fracture, then this common peroneal nerve, which is in close association, it comes from posterior and winds around the neck and goes anteriorly. So in this place, it is in close association with this fibula. So whenever there is an injury or a fracture, then this may get injured as a collateral damage. Once this nerve is injured, clinically you can feel maybe there is a foot drop, loss of sensation. So whenever you examine a patient and whenever you find a fracture like this, then all the more reason for you to examine the associated vascular or neurological status also. So this is a common peroneal nerve getting injured in fractures of the proximal fibula, or there may be a cut injury in knife or some sharp glass. Patient may get injured over that, and it may be a clean cut along with the muscles and all. A nerve may be cut, or sometimes if somebody is shot, then along with fractures or even without fractures, sometimes there may be some nerve injury. Sometimes traction injuries are quite common. If you pull the patient, the joint forcibly, then it may result in injury to the nerves and it may lead to a traction injury. Birth injuries are common example of traction injuries. These Erb's palsy, which occurs after a difficult birth, is a typical example of a traction injury. And sometimes there may be a compression injury. So here, instead of getting cut, this nerve may get compressed because external force comes from this direction and the other side there is a hard bony fibula. So this nerve gets compressed in between this external force and the hard bony structure. So it may get compressed and may get damaged and it may result in nerve injury. And sometimes it may be injured in burns or ischemia. Even in ischemia, if there is loss of blood supply, then even the nerves which are being supplied blood from these blood vessels will be undergoing ischemic changes and there may be neurological complications as well. These small blood vessels which supply the nerves, most of you may remember rasa nervosa, so that though they may get injured or main blood supply is cut, then along with the surrounding, you can see these things in compartment syndrome. We will discuss that when you come to that. Sometimes a chemical injury may lead to neurological deficit. The common examples sometimes these RMPs and all, they give injections. Previously for malaria they used to give chloroquine injections. This chloroquine and hydroxychloroquine, of late they have gained a lot of fame because the hydroxychloroquine was hailed as a drug of choice in COVID for some time. Later it was disputed. Now it's there. If you want to use it, you can use it. This chloroquine injection has to be given deep intramuscular, usually in the gluteal region, and it's very difficult to find a sciatic nerve usually in our dissections. All of you find very difficult, but these RMPs have a knack of invariably finding it and giving injection of chloroquine to the sciatic nerve, with the result the patient used to come to us with the foot drops. I have seen several cases, chemical injury because of injections mostly, and sometimes when they give into the arm, they invariably injure the axillary nerve. They have the uncanny knack. How do they do it? I don't know. I tried several times to injure these nerves with my injection technique, but somehow my technique was not up to the mark, so I couldn't injure these nerves. But you should know that there is a possibility of a chemical injury by injections, by RMPs, by quacks. Never ever try to emulate them. So these are some of the causes of nerve injuries. Coming to the classification of nerve injuries, there are two types of classification. The age-old classification is by Seddon. Seddon is very simple. One is neuropraxia, second one is axontomesis, and third one is neurotomesis. In neuropraxia, which is quite common in orthopedic injuries, here this is a compression injury where there is no loss of anatomical structure, there is no loss of continuity of the nerve fiber. All of you can see here, this is the nerve cell, this is the axon going, these are the myelin sheaths, and this is in between also there is no injury, there is only compression in the middle segment. So how do you remember neuropraxia and axontomesis? What is the difference between these two? So if you remember that anatomy is intact, in neuropraxia anatomy is intact, it is only the physiology which is at fault. In neuropraxia. In axontomesis, there is an injury, anatomical injury to the axon. Here you can see there is a loss of continuity of the axon in the middle segment. So that is axontomesis. In neurotomesis, the whole nerve is cut. So this is in brief about the classification of Seddon. Neuropraxia, anatomy intact, only physiology. Because anatomy is intact, there is a chance that it may come back to normalcy. In axontomesis, because there is a cut, there is cut in the axon, the complete functional may not be restored without intervention. Same thing with neurotoxicity. So the gravity of the injury is getting more and more complicated from neuropraxia to axonotmesis and from axonotmesis to neurotoxicity. So this is Seddon's classification. Another classification you have, this is by Sunderland. So you should know by now that there are two classifications. One is Seddon, another one is Sunderland. He divided them into 5 groups. Here the degree of difficulty is increasing from 1 to 5. But here Sunderland's group 1, this corresponds with neuropraxia. 2 corresponds with axonotmesis, and 3, 4, 5 they correspond with the neurotoxicity of the Seddon's classification. So this is about classification. It's a comparison between these two. Here Sunderland's group 1, 2, 3, 4, 5, and here neuropraxia corresponds with 1 and axonotmesis corresponds with these 3, and as the grade is increasing, the level of injury and gravity is increasing. Here the recovery is none in case of 3, 4, 5 actually. And what are the structures which are injured here? Tissue damage, that only myelin, axon, endoneurium, perineurium, epineurium. The whole total thing is gone in neurotoxicity. That's why the recovery chances are minimal. So this is a graph which depicts both Sunderland and Seddon's grades. So, which we have already seen, the first degree of Seddon corresponds to neuropraxia, Seddon's second corresponds to axonotmesis, third, fourth and fifth correspond to neurotoxicity. If you remember this sentence, then it will tell you that there are 2 types of classifications of nerve injuries, and how can you compare and know that the outcome of a nerve injury. Coming to a neuropraxia, as we have already seen, because there is no anatomical disruption, this is a minimal injury. And this is a transient injury. Only the physiology is stopped, not the anatomy. Physiological nerve conduction is blocked. And because there is no anatomical discontinuity, once there is an anatomical cut, then there will be repair. Once there is a repair, the repair can be of 2 types. We will come to that later. So you all should know that because there is no anatomical cut, there may not be any Wallerian degeneration. That means to regenerate, there will be initially degeneration. Because this is not cut and it doesn't need any major repair process, there will not be any Wallerian degeneration. So this may be useful for you as an entrance bit. So Wallerian degeneration is absent in neuropraxia and Sunderland's group grade 1. Grade 1 injury Sunderland, there is no Wallerian degeneration because there is no anatomical cut. It's only a transient physiological block. Okay, because it is a transient physiological block, complete recovery should occur, and usually we'll wait till 6 weeks. So we know that there is a neuropraxia and we'll wait till 6 weeks to see complete recovery. And the examples are Saturday night palsy and tourniquet palsy. So when we were medical students, this term was much more popular. That means in Saturday we used to think that people go out to enjoy to the nightclubs and the bars during weekends. That is Saturday, if the patient is very much drunk, he doesn't go home, he stays there with arm hanging over the edge of the chair. Then there is a pressure in the axilla, pressure on the cards, and patient will develop something of this sort. But nowadays, with advancements all over, and every day is a Saturday, every day is a Sunday. So this term is no longer useful now. So this can be everyday palsy, every night palsy. You can say that, because everyday people are going out, everyday people are going to pub, everyday people are going to bar. So this term, I think, is no longer relevant. But for you undergraduates, especially in the exam, if you write Saturday night palsy, then we remember, we know that yes, this student has attended classes and he is a good student. Okay, so for now, remember that Saturday night palsy is a neuropraxia, but this Saturday can be every day. And another thing is tourniquet palsy. Tourniquet, usually whenever there is a bleeding, usually outside, they may put a tourniquet. Or commonest tourniquet in orthopedic practice is whenever we are operating on a forearm, we apply this tourniquet on the arm. Whenever we are operating on the leg, we apply this tourniquet on the thigh. So if you leave it for too long, then it may lead to tourniquet palsy. Here there is no anatomical discontinuity. It is only the physiological block which is the cause for this neurological injury. Coming to the second injury, that is, it could be axontomesis. Here there is damage to axons, but endoneurial tube is intact. That is very, very important, because once axon is damaged, if the endoneurial tube is intact, there is some hope, there is some light at the end of the tunnel. So this can be salvaged, but because there is a damage to the axon, then there is Wallerian degeneration occurs. So presence of Wallerian degeneration indicates that there is some anatomical damage to the axon. Then partial or complete recovery may occur in 3 to 6 months. The injury can occur in a moment, but the treatment and the recovery takes long. Treatment may take days and recovery may take months. So the prime example for this type of nerve injury is a traction injury, that's called Erb's palsy. So whenever somebody is delivering a baby like this, when it is stretched, the angle between shoulder and the neck, when it is stretched or pulled, then the baby may have what is known as a Erb's palsy. What is Erb's palsy? We will discuss in subsequent classes. So all of you should note that there is something called a traction injury, and Erb's palsy is example for traction injury, and this may be a part of neurological injury called axontomesis, where there is damage to axons and Wallerian degeneration occurs. The third injury, the ultimate one, is a neurotomesis. That means a cut injury. An injury like this, where there is a clean cut of most of the structures. So most of the tendons are cut, some muscles are cut, vessel may be injured here, or some of the nerves which run into the hand from the forearm, they may be cut. It may be because of a cut injury or lacerated wound, open lacerated wound like this, or some severe crush. Minor crush may lead to neuropraxia, but a severe crush may cut the nerve, or sometimes a severe traction may wrench the nerve root, and that may lead to neurotomesis. And here the nerve is completely severed. Once it is completely severed, then spontaneous recovery will never occur. So spontaneous recovery is out of the question here. And here you have a Wallerian degeneration present, and a neuroma formation is also seen. What is this neuroma formation? We will see. But you all should remember that apart from Wallerian degeneration, this neuroma indication, the formation of neuroma indicates that it is a complete nerve injury. That means a complete nerve is cut. That's why there is a formation of neuroma here. So this is once again an entrance bit. Neuroma formation indicates. Then it needs surgery, because the anatomical continuity of the nerve, total nerve, is lost. That's why you need to put them together and suture. That means it needs surgery for recovery of the function. So these three are the types of nerve injuries which you can encounter in our clinical practice. Coming to the pathology, what are these degeneration, regeneration and all? So when a nerve is cut, then the part distal to the injury, undergoes what is known as a secondary or Valerian degeneration. What that means we will know, but all of you should know for now that distal to the injury there will be Valerian degeneration, but proximal to the injury there will be retrograde degeneration, which is a primary process, and this Valerian degeneration is a secondary. It is secondary or Valerian degeneration. This proximal part undergoes primary or retrograde degeneration. This retrograde degeneration or primary degeneration is the changes which occur in the proximal fiber. This is the nerve and this is the cut area, and this is the proximal end of the nerve and this is the distal end of nerve. So here several changes take place and they are all called retrograde degeneration, and the distal part of the nerve, you find so many other changes which are called Valerian degeneration. So Valerian degeneration occurs in the distal part of the nerve, and retrograde degeneration or primary degeneration occurs in the proximal part. When does it process start? Usually this starts 24 hours after the injury by axonal sprouting from the stump. So you all have seen this is the stump of the nerve. So from here, so the axonal sprouting should start from here, is it not? So because the continuity is here, so it should start from there. If endoneurial tube is intact, that is axon misses, the axons sprout readily and pass across the injury site. If the endoneurial tube is intact, it will be easy for the axons to jump across the defect and try to go to the other side. Here the rate of regeneration will be 1 millimeter per day. As a rule of thumb, any structure, usually even the hair, the nails and the nerve, usually the rate usually say that it is 1 millimeter per day. If the endoneurial tube is not intact, then the whole problem comes. Then the sprouts migrate aimlessly into the epi, peri and into the adjacent area to form a neuron. This is like students and our college. If the college is functioning, then you guys may definitely come to the class as and when you please, and you know where your class is being taken and you can come there. If the class is not there, college is suspended like now, then you will be wandering aimlessly. You may come to the class, online class, or you may be busy watching Netflix or Prime or whatever. So similarly, if the endoneurial tube is not intact, then there will be some confusion. The sprouts may wander aimlessly into epineurium, perineurium. They don't know what to do, but because of they are nerve fibers, the sensation is intact and it is unpleasant sensation, especially from the neuroma. So what you are feeling, even the neuroma will give to the body. Unpleasant. After 4 to 12 weeks, what happens? The regeneration sprouts from the axonal stumps. So the axonal stumps which are cut here, they start sprouting in the hope that they will find their correct place and a nerve can be regenerated. If a axon can find its original posture, original position, original endoneurial tube, then it can function as a normal cell. And when a regenerating Schwann cell from this form a tube to accept from stumps from the sprout from the other. See, this is the distal or Valerian degeneration. Here, this is the retrograde degeneration. They form the tubes in which these sprouts of axons come and sit. So this is how a nerve regenerates. So this is phase of neuronal regeneration, 4 to 12 weeks. Then once they reach, if many endoneural tubes are cut, the number of axons regenerating are large. So every axon wants to regenerate and function normally as before the injury. That's why so many sprouts will be there, and the growth is haphazard because total cut is there. They may not know where to go, and they form a swelling at the growing end. That's called the stump neuroma. This neuroma is a confused structure but sensitive, and it may lead to severe pain for the patient. This is called a stump neuroma, which you can feel from outside. Coming to the how do you diagnose a nerve injury? So, etiology of the injury, how the injury has occurred. A patient comes to you with a foot drop after an injury to the knee joint, and on the radiology, if you find a fracture of the proximal end of the fibula and a foot drop, then you can make a diagnosis of maybe the lateral popliteal nerve injured, or patient gives a history of getting an injection into his buttocks, maybe a chloroquine injection, and after that patient has foot drop. Then you can straight away make a diagnosis that that great doctor has isolated sciatic nerve and he injected the drug into that. In the physical examination also, we can clearly make out the neurovascular status of the affected extremity. You can feel the pulse and all, you can know, and neurological status by sensations you can make out whether the nerve is functioning or not. Or sometimes that is mostly subjective, and if you want to have an objective assessment, then you may need to have this electrodiagnostic studies. If you know the names, I think for now, for UG level, what are the various electrodiagnostic studies which can tell you about the nerve injury, I think that's enough for you. Coming to the clinical features, if it is a fresh injury, then the patient may complain that there is some numbness and paresthesia. That means he will feeling it is differently. And if it is a complete cut, so then there may be muscle weakness. Sometimes say this is a wrist drop, classical wrist drop, where patient is unable to extend the wrist and the fingers. So this indicates that injury to the radial nerve in its course. Then signs, the abnormal posture. See, this is not normal. This is not how you usually keep your wrist, is it not? So once we ask you to extend this, you will be unable to do it. So this is an abnormal posture. This is a claw hand. This is a wrist drop. These two are abnormal. They are not normal. So if you find these things in a patient, then you can straight away make a diagnosis that there is something wrong with his nerves. And there may be some weakness. The patient is unable to function at his optimum level. So then that indicates that there is something neurologically wrong with him. Same, this is a motor function weakness and loss of sensation, sensory. See, most of the peripheral nerves, they are usually mixed nerves. In that, they carry both sensory and motor fibers in them. So if it is cut, there will be weakness, that is a motor function, and loss of sensation, that is sensory part of the nerve, which is responsible for the sense. So it becomes senseless, like most of us. So then it will lead to loss of sensation. So these are some of the clinical features by which you can identify in a fresh injury that there is nerve injury. But the patient may not turn up to you as soon as the injury occurs. So he may come to you very late. Then how do you diagnose these nerve injuries? Then there will be wasting of the muscles. All of you can see there is wasting of the muscles. You should always compare with the opposite side. Here you can see the muscle belly, which is clearly seen here. See, these venar muscles. Here there is wasting of the muscles here. And decreased tone and power, they indicate that this muscle is not being used because of some neurological deficit. That's why muscle is not getting stimulated. That's why the power has gone down and the tone has gone down. And that is a motor, and numbness and paresthesias, and skin. Skin may become smooth, cool and dry because in the skin needs continuous nerve stimulation for it to have these sweat glands to work, and it should be normal for its normal functioning. If the neurological deficit is there, then the skin becomes smooth and cool and dry, no sweating and hydrosis. Okay, and neuroma, you can feel a tinel sign. What is a tinel sign? We will see subsequently. Coming to the features per se, there are sensory. How do you distinguish the examination of the sensory system? All of you know that touch, temperature, 2-point discrimination, all these things. I think it's medical Hutchison will give these things very lucidly. So go and read about neurological examination, then it will be very, very easy for you to understand that there will be some sensory deficits, and these are the tests by means of which you can easily identify. If the patient is unable to detect the variations in temperature, or is unable to detect the touch, or if the 2-point discrimination is lost, then that means that there is something wrong with the sensory part of the distribution. And motor, how do you test? Grade 0 is no movement and grade 5 is normal. So these are the in-between things. Grade 1 flicker, grade 2 movements with gravity eliminated. That means when there is no gravity, the muscle can move. But with the gravity, it can't. So when it moves against gravity, it is grade 3, and moves against resistance. When you are offering resistance, even then the muscle is working, then grade 4. Grade 5 is normal, the normal strength muscle. So these are the muscle grades. When you test muscle motor power, this is grade 0 to grade 5. What is a tinel sign? Tinel sign, if you tap along the course of, once a nerve is cut, then all of you know that it has to regenerate from proximal to distal. So if you want to know whether the nerve is regenerating or not, this tinel sign helps you. So if you tap along the course of the nerve, then you get a funny sensation that indicates the place at where the regeneration process is stopping at that particular point of time. So this is about the tinel sign. You should know about these words for now. We'll discuss them subsequently. Then there is another word called motor march. This is a march where the muscle supplied nearest the site of injury is the first to recover. As common sense dictates to us, whenever some muscles are very close to the site of injury, with the regeneration, they are the first muscles to get back their power first, rather than the distal muscles getting power. It's like whenever water is released in a canal, the fields which are very nearer to the canal, in the beginning of the canal, they receive the water first, rather than the tail end fields, which may or may not get water once the water is released in the canal. Similarly, the muscles which are close to the injury get the power back first, rather than the distal muscles where they are far away from the site of injury. So the muscles, they march. That means the proximal muscles first, then the intermediate muscles, then the distal muscles. So this regeneration also follows a rule. That's why you can identify the muscles which can get regenerated first and which get regeneration last. So once you know the muscles, then you can find this motor march. And these electrodiagnostic tests, they predict the nerve recovery before it appears in the clinically. Clinically, you may or may not be seen, or if the examiner is lax or the patient is not cooperative, it is very difficult clinically to make out whether the nerve is regenerating or not. But electrodiagnostic tests will definitely tell us whether the nerve is getting repaired or not. So coming to the tinel sign, this is a sign seen in the nerve regeneration. When a nerve is regeneration, when you are tapping a nerve at the site of regeneration, then you will find some dysanesthesia. There's a funny feeling. You can't just describe it, but once you feel it, then you will never forget it in the life. So this is provoked by percussion. See, you know that this particular nerve is injured. So once you start percussing from distally, so you suppose this is point A and this is point B. So you want to start here and slowly come up. The nerves is from here to here. So it is coming from above, right? So here you find a funny sensation. So from here the nerve has regenerated up to here. After 1 week this point will migrate distally, and after 2 weeks maybe up to here. So you have to tap from distal to proximal. If the distal muscles have complete power, you should take it for granted that the proximal muscles are already energized. This is motor march, because the muscles get renervated from proximal to distal. So if the distal part has it, then it goes without saying that the proximal part is already the nerve function is present. So this distal tinel sign, previously it was here, then here, then here. This you need to mark it, and every subsequent examination it should go this point where this anesthesia is there. It should go distally. Then it indicates that the nerve is regenerating. I think you understand what I am trying to tell you. So the tinel sign, usually the point goes distally along with the regeneration of the nerve. From here it goes on like this. It indicates regeneration. And as all of you are knowing, this is absent in case of neuropraxia, because there is no anatomical loss. Unless the nerve is cut or an axon is cut, there is no question of any regeneration. If there is no question of regeneration, then tinel sign is absent. Just remember that. That's why tinel sign is absent in neuropraxia. And the investigations in orthopedics, nerve injury, always you should dislocations or fractures. See, hip dislocations, all of you know that hip dislocations are of two types, anterior and posterior, and posterior is quite common hip. And when the hip is dislocated posteriorly, the most important structure in the posterior aspect of the hip is the biggest nerve in the body, the sciatic nerve, and it may get injured and it may lead to a foot drop. The patient presents with a foot drop and hip dislocation. Okay, then once you take an X-ray, once you see the dislocation and that nerve injury is diagnosed along with dislocation. So X-rays can help you, like a lateral popliteal nerve injury in case of fracture of the proximal fibula. If it is difficult for you, then for objective assessment you need to conduct what is known as nerve conduction studies. You know, the signal passes from proximal to distal in the nerve and from distal to proximal, depending upon the motor or sensory, that can be captured, and that velocity can be mapped on paper. That's why nerve conduction studies are very, very important. And there is something called strength duration curve, your physiology, and electromyography. So these are some of the tests which can be done to objectively assess the nerve injuries. So radiography, this is, all of you know that this is a supracondylar fracture, and here this is a clinical real case where we had a radial nerve palsy in a fracture, supracondylar fracture, which is not so common, and medial nerve injury quite common here, we can see. And radial head fractures usually result in posterior interosseous nerve palsy, and this is a comminuted fracture of the leg, and this is a elbow dislocations. All of these are associated with this is humerus. This is humerus. You can see the oblique fracture, long oblique fracture, and this is the head. And what are the nerves which are in close association with this? This radial nerve is in close association with this, and the fracture of humerus with radial nerve palsy is a very important clinical entity, and if you miss it, definitely it will be very difficult for the patient, because if you diagnose this in the first place, then you can open up and see whether the nerve is, what type of nerve injury is there, neuropraxia, axontomesis or neurotomesis, then you can go ahead and repair it. So these are some of the radiographs which are in association with nerve injuries. So a humerus fracture with radial nerve and a supracondylar fracture with median nerve and radial head fracture and dislocation. Here we found association of posterior interosseous nerve along with the dislocation. Coming to EMG. EMG is electromyography. Here you have a graphic record of the electrical activity of the muscle. So instead of asking a patient and noting the subjective findings, this is a better. Here the electrical activity of the denervated muscle is tested here. So the muscle which had no supply, lost blood supply will be tested. Then that will be definitely recorded, and which indicates whether the nerve is injured or not. And this has to be done 15 to 20 days after nerve injury. And if it is there, denervation potential, then it indicates the poor prognosis. That means the nerve is severed. So once the nerve is cut, then the poor prognosis unless you intervene and do something about it. So this EMG is a graphic record, and it should be useful to decide between a complete and incomplete nerve injuries. Once there is a axontomesis is an incomplete nerve injury. The nerve is completely not cut. So you can differentiate between an incomplete and complete nerve injury by means of EMG. And you also can know whether there is a regeneration is occurring or not. Along with Tinel sign, you can have a graphic recording. And Tinel sign patient may not be able to, say uneducated patients and uncooperative patient may not be able to tell you, and Tinel sign may be a bit ambiguous. And the level of nerve injury, all these things can be easily known by subjecting the patient to what is known as EMG or electromyography. One more thing is nerve conduction velocity. So you put the probes in the path of the nerve and you get the graphs and you see and you measure the velocity of the conduction. In a normal nerve, you know that normal velocity is around 70 meters per second. In a motor nerve, the conduction velocity is 70 meters per second. So if there is any interruption, then the decreased velocity, that means it's a compressive lesion, that is not a complete cut. If it is a complete cut, there won't be any, it's a flat graph. Yes. A flat ECG indicates mortuary, no need for casualty. Like that, a flat injury, nerve conduction graph indicates that a complete injury. You need to take measures to repair the nerve, definitely. And if it is a compressive lesion, then it's a neuropraxia, then decreased velocity. It may not be 70 meters per second. It may be around 50 meters per second. But if it is a cut, 0. So by that measurement, you know whether it is complete or incomplete, or there is a compression. Another one we know is strength duration curve. This is a graph all of you have seen during your physiology days. Here, excitability of the muscle and nerve tissue under the test. Both the excitement, the nerve tissue and muscle. So the graphic representation is represented here. So a denervated muscle needs higher strength curve for excitation. All of you know that because the nerve is not functioning, that's why you need more excitation to get that similar strength duration curve. So it is useful similarly to differentiate nerve or muscle pathology or to assess the recovery of the nerve. So all these tests are done to know whether the nerve is regenerating or not. Unless you do these things, then you won't get an idea whether the nerve is trying to regenerate or not. When the nerve is not regenerating even after a prescribed time, then it is time for you to intervene. So, how do you treat a nerve injury? So, all nerve injuries need not put your knife. There is no need for surgery in all neurological injuries, nerve injuries. Usually, if it is a neuroproxia, by 6 to 8 weeks, the function will come back. Till that position, you need to keep the joint in a functional position. For that, these splints are useful. If you leave them like that, the muscles will atrophy. In 6 to 8 weeks, there is a lot of things can go wrong. The function of the joint is gone, and there will be stiffness at those joints and the loss of muscle tone. All these things will lead to some contracture formation. So to prevent all those things, we put them in splints. In a wrist drop, we will give what is known as a cock-up splint. So it prevents the wrist from hanging down. So it keeps the wrist in neutral position and even the fingers. So this is a cock-up splint, and usually cock-up splint comes in stationary and dynamic mode. Dynamic mode, once you flex your fingers, because flexion is present in wrist drop, only the extension is lost, there will be elastic bands attached. Once you flex your fingers, then the elastic bands will make it extend. So once you go on flexing, they go on doing extension for you. So that is a dynamic cock-up splint. Usually in wrist drop, where there will be loss of extension of the wrist and fingers, we put up a dynamic cock-up splint. In foot drop, because of the foot drop, we prevent that foot drop by means of this foot drop prevent or foot drop splint. So this is a splint in 90 degrees, and this is a velcro strap, and thereby this prevents the foot from falling forwards. That means there won't be any drop. The drop is prevented. Plantar flexion is prevented. So this will be like this. And in claw hand, this is a knuckle bender splint which is used to keep them in position. Because this is a neuroproxia, all of us know that the nerve function will come back. Till the nerve function is coming back, this should be functional. See, there is no point nerve function coming back and there is muscle is affected. So that's useless. See, this is like Rama went to forest for 14 years, but there was his representative, Bharata was there, and he was the king for that 14 years. If there was no king, maybe there could have been some anarchy. By the time Rama came back from his 14 years stint in the forest, maybe somebody else may have been ruling that kingdom. So to prevent that, we use these splints. So these splints prevent wasting of the muscles and early restoration of the function. So the splints help us in early restoration of the function once the nerve function comes back. Once the nerve becomes normal, then the muscles will become working, but then this is ready for action. And conservative treatment, physiotherapy has a lot of role to play here, and you are very fortunate to have a good physiotherapist who listens to you and helps you. And coming to the surgical management of a injured nerve, there are several procedures. They are called neurolysis and NEURORRAPHY, nerve grafting, reconstruction procedures. Neurolysis means once the outer layer becomes very thick, then unless you open that, the nerve function may not be adequate. So that is called neurolysis. NEURORRAPHY, individual fibers, they are sutured back. Nerve grafting, if there is a loss of nerve, a section of the segment of nerve is lost, then you need to put another nerve there and do the grafting. And nature is so great that it has provided one or two spare nerves in the body which you can use it for a nerve grafting. Usually the sural nerve which is present in the leg can be taken for nerve grafting. So even if you take out the sural nerve, there may not be much loss of function. So that can be used for nerve grafting. And if everything fails, and if you feel that nerve grafting or nerve repair may not achieve adequate results, or the surgeon is or the center is not capable of doing these specialized procedures, then we resort to what is known as reconstructive procedure, where we transfer some tendons. The functioning tendons are transferred to the tendons which are affected by the nerve injury. That means in wrist drop, the extensors are not functioning, the flexors are functioning. So some of the flexors are rerouted and they are asked to do the job of extensors. So that is a basic principle in the tendon transfers. If everything fails, then the joint on which all these muscles which are acting are useless, then we'll fuse the joint. Once you fuse the joint, there is no movement at the joint and you don't need any muscle to move the joint. When the joint itself is immobile, you don't need that muscles. Even if the muscle is not working, even if the muscle is atrophied, that function can be done because the joint is fused. So these are some of the surgical procedures we can resort to in nerve injuries. So what is neurolysis? See, neurolysis is removing the encircling fibrous tissue and the decompression. So all of you can see this is the nerve. So this is actual surgical diagrams. When we are operating, we see this nerve is compressed by lot of fibrosis. After injury, body tries to repair it. So once body tries to repair it, a lot of fibrous tissue will form. And once fibrous tissue, as all of you know, is unyielding. Like most of our students who doesn't want to come to the class, whatever you say. So they are very unyielding. Similarly, this fibrous tissue is very unyielding and is compressing on the nerve. So once you remove that fibrous tissue like this, these are the retractors, self-retaining retractors. And this is a red rubber tube. You should be very gentle while handling nerve. As we have already said, this is like a girlfriend. So you should handle them with care. Otherwise, they show their attitude. So you will have a lot of problem if you are very rough with the nerve. So this is a neurolysis where the fibrous tissue is removed. You resort to what is known as NEURORRAPHY. That means end-to-end repair of the nerve. Then it could be a epineural repair or a single fascicle you can do. Single fascicular repair, you need to have a microscopic vision. That means you need an operating microscope to resort to that. Epineural, the whole bundle you can see and you can repair that also. But the results are much better in fascicular repair rather than in epineural repair. In epineural neurorraphy, see these are cut ends of the nerve. So this is proximal, this is distal. Suppose this is a sciatic nerve injury which is cut. So you bring these two together and stitch like this. So you allow the ingress of, this is a proximal, the nerve, these are the nerve fibers, and this axon, the sheath is intact, and this grows from here to here, and the distance is very much reduced by means of your sutures. That's what you have done. You have sutured only the epineurium. You didn't touch anything. This is epineural neurorraphy. And the other things, it has to find its counterpart here and it has to grow into this. If it does that, the function is excellent. If it can find its partner and go there, fine. But it doesn't do so, and these fibers grow into this, then all hell breaks loose. Okay, so this is the problem with epineural neurorraphy. Then this is the nerve and these are the fascicles. So you can individual fascicles also you can suture. You can identify this as belonging to this. See, this looks very easy diagrammatically, but once you are on the field, it is very difficult, and to identify them, you need to have some specific enzymes. You stain them with specific enzymes and identify this fascicle should unite with this. So you suture them both like this. This is the final product. If you suture them like that, then the function is much better with a fascicular neurorraphy than with epineural neurorraphy. I think you can clearly understand what is happening here. Sometimes, see, this is an injured nerve and this is a damaged segment, and whatever you do, this damage which is permanent cannot be redone. So what do you need to do? You need to resect it till it is the normal one. So this is the damaged segment and which is removed. So you need to have a graft. to bridge this gap. So what are the nerves which we have can be used as a graft? Sural nerve or sometimes lateral cutaneous nerves of the thigh. So this is mostly a sensory nerve. So that's why their motor functions are minimal. So even if you sacrifice that nerve, there will not be much loss for the patient. So the sural nerve and lateral cutaneous nerve of the thumb can be isolated and they can be used as bridge between these two cut, damaged, severed nerves, and this is the graft which is put there and nerve function will be restored over a period of time. So this is cable graft, means you make multi strands with a nail, the nerve, and put 3 or 4. This is like braiding several. This is cut end of a nerve and this is the other end of the nerve, and instead of putting only one, you put multiple strands, so that with the hope that at least a few will take up the function in real earnest and the nerve function is restored to a large extent. This is like hoping that 100% of the students attend class and 100% of the students are attentive and they listen to whatever you say and they definitely do well in the exam. So this is like hoping against the hope. So if A doesn't do it, B will do it. So this is about cable graft. Instead of putting one, you put a multi-strand free nerve graft. This is called a free nerve graft. You take up 2 or 3 sural nerve, make 3 or 4 segments and take also lateral cutaneous nerve of the thigh. You put 3 or 4 of them strands like this, suture it here in the proximal end, suture it in the distal end, and hope that this cable graft works much better and the function is restored. So when do you do the reconstruction procedures? You should not be in a hurry. As soon as you get the patient in casualty, don't be hurried to do these exercises. So this should be reserved if the patient has no recovery after 15 to 18 months. This is like waiting for 1.5 years for the patient to regain complete nerve function. If the patient doesn't have any, then you should go for one of these procedures. And if the repair is done or if the grafting is done and if they are failed, then you do these reconstruction procedures. And what are these reconstruction procedures? Tendon transfers and arthrodesis. What are the common principles on which these tendon transfers are made? So as we have seen, the flexor tendons are transferred to extensors in case of wrist drop. There are some principles. If somebody has to donate, he should have enough money to donate. If I don't have enough money, how can I donate? So similarly, a donor tendon should have minimum power of 4 by 5. 5 is ultimate, normal. At least 4 it should have, because after transfer, this donor will lose 1 grade of power. So if the donor has 3, the minimum power which is of use is 3. If the donor tendon has 3, after donation, after transfer, it becomes 2. That becomes it becomes useless. See, I should not be fooled to donate what all I have. If I donate everything I have, I will become a pauper. Similarly, a donor tendon should have enough power so that it will lose 1 grade after this tendon transfer. So the minimum power, it should be 5 by 5 ideally, or if it is 4 by 5, yes, we can go for it. If it is 3 by 5, no. The donor itself is weak. So how can the transfer will become successful? It's not. So you should never transfer if the power is below 4 by 5. And the recipient side, the joint should be having good range of movements. See, if the joint which is receiving the tendon transfer, if it is stiff, there is no point to do the tendon transfer. You contemplate doing a tendon transfer in a mobile joint, and there should be no scarring because of the previous injuries. If there is a scar, then the muscle may not be sliding properly, or there may be some problem after the nerve or tendon repair or grafts, so that there should not be any scar. Technically, it should be in a straight line. So, if it is made to run around in loops, then it will not be possible to exert its action. So, it should be a straight line and it should be placed in subcutaneous space so that it can move freely. There should not be any hindrance when the tendon muscle is contracting and tendon is sliding. There should not be any speed breakers in its path. So it should be something like an expressway. It should be straight, no speed breakers, something of that sort. And it should be fixed under adequate tension. So you do a tendon transfer and it's not very lax at that time. So even with the muscle contraction, when the tendon is trying to act, if it is lax at the sutured side, then the distal part is not going to act. So it should be fixed under adequate tension and it should be subcutaneous space and it should be in a straight line. So tendon transfer is not easy unless all these things are properly present. Your procedure becomes a failure. So usually we do what is known as a Jones transfer for radial nerve palsy. In radial nerve palsy, you get wrist drop, as we have already seen. So the wrist is not getting extended and the fingers are also not getting extended. So these are some of the pronator arteries. This is a flexor group of muscle, flexor carpi ulnaris and palmaris longus. So all these things are in the front of the forearm. So they are made to go back and perform the functions of the extensors. So this is a Jones transfer. If you remember that Jones transfer is done for radial nerve palsy. Whenever there is a wrist drop, so these are the tendons which do the work of the damaged tendon. Okay. So coming to the prognosis of nerve injuries. So if the younger the patient, the good the prognosis, because the better the prognosis, because the younger patient growth potential is much more than older patients. That's why good prognosis. And if it is a sharp injury, cut injury with the minimal soft tissue damage, it's much better than compared to ischemia, burns. And burns and ischemia, you have a lot of fibrosis and scarring. All these things will make your surgery a thankless job. So the prognosis is worse in a burn or ischemic nerve injury rather than a sharp cut injury. Sharp, fresh cut injury is much more better. But you desire to do a nerve injury repair, it is better to do it on a sharp cut injury rather than in a burn or ischemic injury, and you will burn your fingers after repair. And the type of nerve, pure motor, very good chance, because there is no sensory fibers in that. In a mixed nerve, you have motor fibers and sensory fibers. If you stitch motor fibers to sensory, then the function may not be optimum. So if it is a pure motor nerve, then definitely the prognosis is good. And as we have seen, a proximal lesions, poor prognosis. The proximal the injury, the more the damage. So if the nerve is very much injured, proximal to say a brachial plexus injury is a serious injury when compared with a medial nerve injury. So proximal lesion, poor prognosis. And delay, time also matters. Delay in repair reduces chances of recovery. So once it is done in the optimum period, you will get optimum results. If you delay the surgery, the results will be very poor. Thank you very much. This is something about nerve, types of nerve injuries, how they get injured, how you clinically examine, and what are the investigations you should conduct, and what are the various types of treatment, conservative and surgical. And next class we will deal with individual nerves like radial nerve, ulnar nerve and medial nerve. So this is our own Hyderabad tank bund, and this is Buddha, and maybe last monsoon, I don't know when the picture was taken, but yeah, picture speaks. more than 1,000 words. A beautiful sight here. So at least throw some light and learn some orthogonals. Thank you very much.